Hello, everyone. Thank you for joining me today. This is Jennifer Gross at PointRight. Appreciate your time this afternoon to talk about the proposed rule. So just a few housekeeping items before we get started. All the audio lines are muted, so if you have any questions, just use the chat or questions and answers in the GoToWebinar toolbar and type in your message, and we'll be looking for those throughout the presentation. Also, there's a handout from these slides. It's attached to the toolbar, so you can click on that and download the PDF of these slides. And at the end of the presentation, I'll tell you how you can get your continuing education credit. We are approved for one contact hour for nurses and for nursing home administrators. Okay, so, and before I dive into the content, I just have a little disclaimer. Firstly, the information that we're going to be going over today is a summary, it's an overview, it's for educational purposes only. It's up to you and your organization and your compliance teams to interpret the regulations and create your own guidance about your policy going forward. So that's up to your legal team, your compliance team, and your care management. And also, remember, this is the proposed rule. So there certainly is the opportunity for things to change between now and when the final rule comes out in August. So make sure you just take a look, or there's always a lot of great summaries that are being published when the final rule comes through to find out if there's anything that's significantly different between the proposed and the final rule. Okay. So today's objectives over the next hour, when we're finished here, you should be able to, first of all, summarize what the key changes are in the Medicare Part A fiscal 2022 proposed rule. You'll be able to discuss what the implications are potentially for the changes and the updates to the SNF quality measures that will be implemented. You'll be able to identify 3 areas in your documentation in the SNF that might be subject to some scrutiny by auditors because of what CMS has been telling us over the last couple of months. And you'll be able to identify and apply 2 strategies to reduce your audit risk through your compliance program and through your day-to-day best practices. All right, so we are going to start off with the overview of the updates from the proposed rule. So proposed rule, just a little background on this. This happens every year with the seasons. It's formally known as the NPRM, the Notice of Proposed Rulemaking. And this is a statutory requirement for CMS and other government agencies to make publicly available what they propose to do and what changes they propose to make for the following fiscal year. So this is an annual thing. It comes around every spring. And then there is a 60-day comment period for public and stakeholder and providers to comment. And actually that comment period just closed yesterday on June the 7th. So hopefully you've had the opportunity to enter your comments if you have any. And there have also been comments that have been submitted by the healthcare provider organizations as well. So usually what you'll find in a proposed rule are, of course, the what CMS plans to do with the Medicare annual payment update for the next fiscal year. They're always tweaking and making changes around the edges. Any changes that are being proposed to the Medicare Part A case mix classification, i.e. PDPM, in this case. And if there are any proposed or updates or changes to SNF quality reporting, so things like the quality reporting program, the value-based purchasing program, things like that. Those are generally at least floated in the proposed rule. Now, another thing that you can find in the proposed rule, there's a lot of kind of boilerplate language that you tend to see in every single proposed rule, but you should kind of try to read between the lines, because there's usually a lot of commentary from CMS as to what rationale they came by their proposed changes. And this really kind of raises a little bit of a flag to areas that they are potentially going to be scrutinizing going forward for compliance sake. So let us take a look at the numbers. So the proposed rule was released on April the 8th, and the comment period, as I said, closed yesterday. So what we are looking at is, first of all, the good news: an aggregate increase is being proposed that totals out to approximately $444 million. So that's a 1.3% aggregate increase. Now, within that aggregate increase, of course, there's putting some here and taking some away from elsewhere, as usual. So in the green box on the screen, you can see that this increase is comprised of an overall 2.3% market basket update, and then minus 0.8% forecast error adjustment, and minus 0.2% multi-factor productivity adjustment. I'll talk about these on the next slide. So overall, the payment update is an increase, but then there is also a proposed decrease in the annual payment update because blood clotting factors that are used for hemophilia, for example, are being excluded from SNF consolidated billing. So like other high-cost medications and treatments, the blood clotting factors are going to be taken out of consolidated billing and will be billed for separately. And this also does not include the estimated impact of SNF VBP changes for fiscal 2022 that is being estimated at about $184.25 million. And I'll talk about VBP a little bit later in the program. So it took me a while to learn what all these adjustments are. So I thought it would be helpful to just kind of give some basic definitions of what these adjustments mean. First of all, what's the market basket update? So these updates every year are intended to reflect changes in the cost of goods or services, goods and services as compared to a base period. So first of all, what are the cost of these goods and services, and how do they compare to whatever that base year was? Now, because the cost of things changes, there's usually inflation over time. So the market basket base period is rebased every 5 years. So CMS is proposing to update the base year to 2018 to make it a little bit more current. Then there is a thing called the forecast error adjustment. And the forecast error adjustment you can probably tell, adjusts for errors from prior forecasts. That's basically the definition here. So what this really means is that the actual costs of Medicare in SNF services for fiscal 2021 were higher than were projected by CMS. So CMS needs to kind of try to adjust for that going forward to maintain budget neutrality. And then there's the multi-factor productivity adjustment, and this adjusts for changes in the overall economy, what's called non-farm productivity. Not to denigrate any of you farm folks out there, because you're very productive, but the multi-factor productivity adjustment is used throughout the government for economic metrics that are related to economic activity, except for farming. So that's my non-economist explanation of what those numbers mean. So what are we actually seeing that is proposed to change to PDPM? Well, honestly, not a great deal, even though the overall rates, and let me just back up 2 slides here, even all the overall per diem rates and CMIs are adjusting and changing to bring the numbers back in line to what CMS is projecting. The actual mechanism for setting payment, PDPM, there's really not a lot of change. So let's first of all talk about the change to PDPM. All we're going to see is a change of some ICD-10 codes mapping. Now, there were several ICD-10 codes in fiscal 2021 when PDPM was first came into existence that mapped to return to provider, that are going to map to a clinical category beginning with the next fiscal year, and vice versa. So here's the table. I put in a brief description of what these ICD-10 codes mean. So if you're not a coder and you don't have all these memorized, which I don't, there are diagnoses related to sickle cell thalassemia that mapped to medical management. In fiscal 2021, CMS is proposing to map that to return to provider, so it will no longer be an acceptable PDPM primary diagnosis. Remember, even though a primary code maps to return to provider, that doesn't mean you can't use it in one of the secondary ICD-10 codes. Now, the reverse is true for 3 codes for esophagitis with bleeding and GERD with bleeding. Those map currently to return to provider. They're going to go to medical management. Multisystem inflammatory syndrome currently maps to non-surgical orthopedic musculoskeletal, but it's been determined that that's really more appropriate for medical management. So that's going to move. And then there are some interesting other changes. Neonatal cerebral infarction. There are 3 codes for this that currently map to return to provider, but are going to map, not surprisingly, to acute neurologic. So I can only speculate that there are some pediatric SNFs out there that have needed to have this code mapped. Then there's a new code, U07.0, for vaping-related disorder. And I believe that vaping-related disorder came into existence last April 1st at the same time as the COVID-19 diagnosis, if I remember correctly. And currently that maps to return to provider, but in fiscal 22, it'll map to pulmonary. And then lastly is anoxic brain damage, which mapped to return to provider and is going to map, as you would imagine, to acute neurologic. So what this means is that there is more appropriate and more accurate ICD-10 mapping for certain conditions. So as always, make sure that you are picking the correct ICD-10 code for the primary diagnosis that a SNF patient is receiving care for in your SNF. But this makes it a little bit easier for you to map to a clinical category and get the appropriate reimbursement for your primary diagnosis. But that's really the only change to PDPM that is a technical change to the payment model itself. There have been no changes to the actual mapping of the CMI as far as the MDS coding is concerned, just the diagnoses. But the big shift here that I also want to talk about is the parity adjustment. I want to spend a few minutes talking about what that means. So basically, CMS always says every year that these changes to the payment model or changes to reimbursement are budget neutral, and they very often are not budget neutral. So what happened, surprise, surprise, when we switched from RUG 4 to PDPM at the beginning of fiscal 2021, although it feels like it was a lot longer ago, that of course was intended to be budget neutral. But what actually happened was that overall SNF payments in fiscal 2020 increased by 5%, or $1.7 billion. So that's a lot of money that CMS did not budget for. So the parity adjustment is a recalibration of the case mix indices across all the PDPM components to reduce that overall total spend by 5% to accommodate for that, that underestimation of 5% in the previous fiscal year. Now, CMS is going to be doing the math on this, but they have options that they are presenting in the proposed rule for how they're actually going to do this. They do not intend to just make a 5% across the board payment cut right away beginning October 1st. So the options that are included is a blanket cut across the board, but with delayed implementation, or a phased implementation beginning sooner, but with smaller reductions per year. So this is one of the big things that CMS requested feedback from providers on during the comment period. And from the comments that I have read, I haven't had a chance to read them all, but it looks like providers want basically a combination of both of those options, which is not surprising because providers really rely on having projective reimbursement that they can accurately budget for. So let's take a look at what was actually found. So when CMS looked at the CMIs, a lot of acronyms here, the case mix indices for fiscal year 2020, what they estimated versus what actually happened. So in this table, we have all the PDPM components on the left. The second column is what CMI was expected. So back in fiscal 2019, this is what they estimated would happen. And then the actual CMI in fiscal 2020 from when reality happened. And then what CMS did when they were doing this analysis, and they were very transparent about this, they were clear about it, and I thought this was good, is that then they also did this difference in the expected to actual CMI, and the sample of patients that they used for this calculation excluded any patient in fiscal 2020 that who had a COVID-19 diagnosis or the DR code, which meant that the patient was skilled for Medicare without the 3-day hospitalization stay, so utilizing the waiver. So this is how CMS kind of accounted for the fact that, yes, COVID-19 had a huge impact, but they wanted to normalize for that and make sure that what they were looking at as far as the change from expected to actual was actually related to the switch to PDPM without the complication of COVID-19. So what we saw here is that PT and OT had either a negligible change of less than 1% or no change whatsoever in OT. And we're looking at this third column here to compare. But speech, nursing, and non-therapy ancillaries had very significant changes, all an increase. So SLP is the most significant, with a 20% increase in CMI. Nursing was up 13% from the estimate, and then non-therapy ancillaries were up 6% from the estimate. So these are the areas, in case you were wondering, are areas that would most likely be ripe for compliance monitoring going forward. And this is really shouldn't be a surprise. So we'll speak to those specific things going forward. Okay. So let's talk about the MDS coding and the documentation that drives those three case mix groups, the SLP, the nursing, and the NTAs, to look specifically at how you should code, what types of documentation you're going to be looking for, so that you can make sure that your foundation is solid for ensuring that you get the reimbursement that you're expecting without any risk of any takebacks retrospectively. So, as I've said, those PDPM components that have the largest increase in the CMI, the SLP and the nursing and the NTAs, are very, very heavily influenced by capturing diagnoses and comorbidities and resident conditions. So the coding of the MDS itself, which is based on the supporting documentation in the record and interdisciplinary communication, are really the key to getting appropriate reimbursement. So what we did here at PointRight is we calculated some trends from our national MDS database, and this is comprised of approximately 2,400 SNFs who submit MDSs to PointRight. And we calculated some trends over time from Q3 to Q4 2019, so from pre-PDPM to the beginning of PDPM through Q1 2021, to kind of give a flavor for where those areas really shifted the most. So firstly, let's look at the nursing case mix drivers. And the big drivers that I'm looking at here are extensive services, that's the green line, and depression, the depression end split, which is the blue line. So here's pre-PDPM. So this is Q3 of 2019, calendar year 2019. And you can see that the rates for both of these items were significantly lower between Q3 and Q4. Now, CMS, if you've ever heard them present on this, are very clear that they are seeing things that have shifted just simply between Q3 and Q4 of 2019 that they are attributing to the change in the case mix model because there are areas that you're focusing on more that have more of because they have an impact on reimbursement versus under RUGs when you were primarily interested in therapy minutes, ADLs, and extensive services. So this is the case here. For capturing the depression end split, the rate of the depression qualifier increased by 5% just between Q3 and Q4 2019. So right off the bat, you can see that change here, and this is an area that certainly would want to make sure that you're solid on your documentation and follow-up when you are administering those PHQ-9 assessments or interviews and appropriately capturing symptoms of depression. Now, for extensive services, this is a little bit more complicated because there was hardly any shift between Q3 and Q4 of 2019, which is not surprising because there's generally a baseline level of extensive services that are being provided in the SNF. You know, if you didn't do trach care in September, you're probably not going to be doing it in October unless you have a new type of patient coming in. However, Q1 2020, there was about a 5% jump in extensive services. Now, I am putting this line here for COVID-19 to be approximately when the public health emergency was declared on March 13th of 2020. And you can see here that extensive services, not surprisingly, shot up from 7.3% to 21.7%, just simply between Q1 and Q2 of 2020, and have remained, although decreasing gradually, significantly above that baseline of Q4 2019. So, I mean, this is the easy pickings. The first place that an auditor would look is ensuring the appropriateness of something like isolation, or if ventilator care is being coded, for example, that those are backed up in the care plan and the documentation for that time period. So that's pretty obvious. Now, when we are looking at specifically the COVID-19 diagnosis and capturing isolation, again, this is the percent of assessments that this is being captured on, and COVID-19 public health emergency was here. Now, for isolation, that item specifically, not just all extensive services, increased from 2% all the way up to almost 14% between Q1 and Q2. Again, not surprising considering the public health emergency. Now, the COVID-19 diagnosis did not exist until April the 1st of 2020. It didn't become effective until that date, so I can't trend before then. But this is the COVID-19 diagnosis tracking at about 16% and then down again, and then back up to 19.9% in Q4, a little bit of a holiday surge, and then gradually going back down again. And I only have this through Q1 of 2021, of course. So this is continuing to trend downward, thank goodness. So what I want to point out here, though, is even though the COVID diagnoses have shot up and come back down again, and the general directional trend follow each other with the isolation and the COVID diagnoses, they're not right on top of each other, which is totally appropriate. Just because there is a diagnosis of COVID for a patient does not necessarily mean that they require isolation or that isolation is even possible. If your facility is completely full, you don't have any private rooms, and you cannot free up a bed to provide single room isolation, and you are appropriately cohorting COVID patients together, then of course you would not capture isolation on the MDS. So I liked that this trend didn't, it got very close for a while, but they didn't lay right on top of each other, which would probably be concerning. Oh, and that's where the diagnosis became effective. So talking specifically about compliance and capturing that COVID-19 diagnosis, there were very specific CDC guidance that came out with the initial implementation of this diagnosis, and then the guidance was updated for 2021. So remember that you can only code that diagnosis if there's a confirmed case that is documented by the physician or nurse practitioner or the provider. And that would include either a positive test result or a physician's documentation of a likely diagnosis of COVID-19. Now, there may be additional diagnoses that go along with that, such as pneumonia, bronchitis, acute respiratory distress due to COVID-19. But in this case, you would code according to the organism that's coding it. So there, for example, there is a specific pneumonia diagnosis code for pneumonia due to COVID-19. And then there is also a Z code for contact with and suspected exposure to COVID-19, Z20.822. So there are other codes that you can use in addition to, or in some cases instead of COVID. So for example, if you are if you have a new resident that comes in, they are suspected of having COVID, you're waiting for the test results and waiting for the physician's documentation, and you are putting them on protective isolation for the beginning of their stay. Make sure that you capture the suspected exposure to COVID-19 diagnosis in the record there so that you have something to back up the reason and the rationale for that isolation. And this URL on the screen is a link to download the ICD-10 guidance. Now, speaking of isolation, just remember, in order to actually capture isolation on the MDS in Section O, which is what is the qualifier for extensive services, the resident has to meet all 4 of the criteria in the RAI manual. So now this item does have a 14-day look-back period, not counting prior to admission, but the resident could be on isolation for just a short period of that. That might be for 3 to 5 days, for example, during that look-back period. It does not have to be the whole 14 days, but during that time period, make sure that the resident meets all 4 criteria. So that includes an active diagnosis of highly transmissible, epidemiologically significant pathogen, that the resident is alone in their room, no roommate, and that any treatments or therapy are being brought in to the resident, and that transmission-based precautions are being maintained. Now, if there is a medically necessary reason why the resident needs to transport out of the facility, such as for dialysis, there are specific CDC guidelines for precautions during that transport. But in general, the isolation has to be single room for all other times. So just make sure you have that well documented so that you can support your capture of diagnosis, because as you can see, the shift in extensive services was very significant, and it's definitely a target for compliance monitoring. I just want to talk for a second to wrap this topic up on cohorting versus isolation. So, as I said, isolation is a very, very specific thing. It is requires single room isolation, et cetera, et cetera. However, many facilities are appropriately cohorting residents with the diagnosis of COVID, or it could be another diagnosis. If you have a flu outbreak or norovirus outbreak, please God no, because there's enough going on in these days in SNFs. But if there's some other outbreak that's happening in your center that might require cohorting your residents that have that diagnosis for a time to contain that spread, then that's certainly appropriate. So what cohorting is taking residents with the same infections and grouping them together in a confined area so that you're minimizing contact with non-infected residents and non-infected staff. So that includes transmission-based precautions in that area, dedicated caregivers, Supplies are not shared with the rest of the facility. Some facilities, if they are physically able to do so, might have separate entrances to that cohort area. Anything you can do to kind of just sequester those infected folks out of the way to prevent the spread until the infections are resolved. Now, as I said, a COVID-19 diagnosis does not automatically equal isolation. Cohorting can certainly be used if necessary to control the spread of the infection if you don't have the capacity to isolate a resident, but you cannot code it as isolation on the MDS. All right. Another thing, another area that had multiple changes is the SLP case mix drivers. So these drivers are cognitive impairment in the green line, swallowing disorder is the dark blue line, and mechanically altered diet is the light blue line. So again, pre-PDPM baseline compared to post-implementation of PDPM and then COVID-19. And you can see that again, a very stark increase in cognitive impairment. So there's two items, the depression and cognitive impairment that were really, really low before PDPM and are really, really high after PDPM, and both are based on either a staff assessment or a resident interview. So making sure that those resident interviews are well documented and are being administered appropriately will only back you up when you're capturing these comorbidity qualifiers. And you can see that this trend has continued high since then. COVID kind of complicates the process of interviewing people because of isolation or other precautions, but just making sure that these comorbidities such as cognitive impairment are being accurately captured and documented on is very important. Now, the swallowing disorder is another thing that had a big increase right at the implementation of PDPM and then has remained stable. Swallowing disorder is such a small section of the MDS, and it doesn't require a specific diagnosis, so it's very easy to overlook it. But when it's identified, it is an SLP comorbidity, so you want to make sure that it's documented and followed up on. So, swallowing disorders and mechanically altered diets. First of all, swallowing disorders. This is based on a kind of overlooked section of the MDS, KO100, for signs of a possible swallowing disorder during the 7-day look-back period from that MDS. Now, this is a possible swallowing disorder. This doesn't require a physician to diagnose dysphagia or anything like that. Just any signs that there's some difficulty that the resident is having when they are swallowing their meals, their snacks, their liquids, anytime during the look-back period. And this could be coughing or choking during meals. It could be pocketing food. It could be complaining of pain when the resident is trying to swallow. It's important that folks are aware of these potential signs of swallowing problems and that they see them and they communicate them to somebody who can document it in the record. So, of course, if a nurse or a CNA who has their own documentation in the resident's record identifies these issues, they can do the documentation themselves. But think of people like your dietary staff, your activities staff, who are also interacting with your residents when they're having meals, when they're having snacks during activities, during medication passes, of course your nurses, or if you have medication aides in your state, may be interacting with the residents during their med pass, and they're swallowing during the med pass. So make sure that you're keeping an eye out for those as well. But the important thing is to either document when these swallowing issues occur, or communicate to somebody who can do the documentation so that it is captured and then it makes its way onto the MDS. It doesn't have to happen every day, but just identify when those issues with swallowing occur during the look-back period in the MDS. Now for mechanically altered diet. Of course, the diet for meals that a resident receives in a nursing home conforms to whatever their dietary order is. So that should be documented in the record. If a resident has their diet order is for a mechanically soft diet, or for ground meat, or for a puree, or if they need nectar consistency thickened liquids, that is documented in the record. It makes its way onto their diet order tickets that go to the kitchen for their meals. But again, going back to activities, it's also really important that the activities folks are aware if a resident needs thickened liquids and they're participating in activities, that when they get their snack, when they get their drink to go with the snack, that they have the appropriate consistency of liquids. So anytime that resident is consuming food by mouth or drinks by mouth, that ties into capturing swallowing disorders and mechanically altered diets. Now, a little tip about this. When CMS was talking about the analyses that they have done and tracking changes in coding the MDS before and after PDPM, when they were talking about the increase in capturing of swallowing problems and swallowing disorders on the MDSs, they also tracked the utilization of speech language pathology therapy. And that, not surprisingly, did not also go up with the increase in identifying swallowing problems. So CMS has noticed that simply identifying swallowing problems better on the assessment of the resident, what's the next step to that? You identify a problem, then how is it followed up on? Now, of course, not every resident who complains of a sore throat when they're swallowing, or maybe does a little coughing when they swallow. Heaven knows I do that occasionally. That doesn't mean I need necessarily speech language pathology, but it's worthwhile to just make sure that you follow up if you identify these swallowing problems, and refer it to perhaps your speech therapist for a screen or an evaluation. And if it's medically necessary, then that speech therapist can get the resident on caseload, whether they're under Part A or under Part B, and make sure that the resident's getting the care that they need that's medically necessary, just kind of tying together that whole process of assessment through to treatment. Now, looking at depression and cognitive status, as we saw in those trend lines, they both kind of trended up very significantly pre and post PDPM. And as I mentioned, during the pandemic, when there are periods of isolation or cohorting residents together, you want to minimize the usage of PPE and make sure that the spread is contained in your facility. But there is still a requirement that interviews have to be attempted if that resident or patient is at least sometimes understood, and those guidelines are in the RAI manual. So make sure, firstly, if there is an interpreter that is needed, the resident speaks another language and they need an interpreter to properly administer the interview, but they're not available, then make sure that you say no to the gateway question should the PHQ-9 or BIMS interview be conducted, and then move on to the staff assessment. But there are cases where an interview should have been attempted but was not. The residents at least sometimes understood they don't need an interpreter, but the interview was not done for whatever reason. So just make sure that you're correctly coding the MDS on that the gateway question should be, yes, you should be doing this interview, but then dash the interview items and do not complete the staff assessment. And this is really important because that makes a difference in the whether or not the depression or cognition qualifier applies to PDPM if an interview was done or was not done. But make sure that you document, if no assessment was done, that you document the reason for that in the record. Again, just making sure that if anything unusual happens, you've got it documented so you can refer back to it if the record came under review. One last thing for the non-therapy ancillaries, this is a little bit different because there is a lot of moving parts to the NTAs. So in this bar graph, I split up the NTA comorbidity categories by the points, from the highest multiplier, 3.24, way over here, to the lowest multiplier, which is 0.72 down here. So these last two categories, NE and NF, actually are negative multipliers for your case mix index. So you definitely want to be able to capture comorbidities as much as possible. And the difference between 2 points and 3 points can be the difference between a negative multiplier and a positive multiplier. So it's really important to appropriately capture that. But you can see here that from Q4 2019 through Q2 2020, there was an increase in all of the CMI groups except for the NF group, which had a downward trend. The NF group has no comorbidities whatsoever. Now, one of those NTA comorbidities, as you know, is isolation. So that happened a lot. So that that accounts for some of the increase in NTA points. But just remember that any non-therapy ancillary point that you're capturing, again, is well documented, because this has to do with a lot of diagnoses and other comorbidities and conditions. So just a word about coding active diagnoses on the MDS. Again, the guidelines and the rules in the REI manual are very specific about this. So firstly, the primary diagnosis is the one that drives the case mix, the clinical category. That's the biggie, the I020B. So the primary diagnosis is the reason why that patient or resident is in the skilled nursing facility receiving skilled level of care. Now, this primary diagnosis should be an interdisciplinary decision. It shouldn't be determined by one department over another. It should be a collaboration to determine, hey, what's the main reason that this person is here? Because if somebody is receiving skilled therapy to rehab a hip fracture, but they could do it at home if they also didn't have COPD, then the reason for that, for the resident being in the facility, may very well be something different. Now, also remember, though, that the other active diagnoses in the record are very, very important. You want to make sure that you capture those appropriately in the checklist in the MDS section I and in section I-8000, where you code the ICD-10 codes, because these other diagnoses count for SLP, for non-therapy ancillaries, for the nursing component. And with any diagnosis on the MDS, you need to make sure that all of the coding requirements are met, which includes documentation from the physician or physician extender during the last 60 days, and that diagnosis is what is considered active within the last 7 days, basically a diagnosis that is driving the care plan and is affecting the resident's current function, their risks, their need for monitoring, their medications and treatments. So both of those criteria need to be met in order to even code a diagnosis on the MDS. So if there's a history of something that is not currently impacting the care plan, it would actually not be coded. All right. So just a few other considerations about PDPM that I want to talk about. Firstly, now the waivers that were put in place to allow more flexibility to provide services to Medicare beneficiaries have been very useful during the pandemic, particularly the 3-day waiver, enabling facilities to skill in place without having to send a resident out for a 3 midnight qualifying stay. Now, what CMS said in the proposed rule is that out of all SNF Medicare stays during the pandemic and going forward through the time of the proposed rule, approximately 8.9% of those Medicare Part A stays included a COVID-19 diagnosis, whether it was a primary diagnosis or a secondary diagnosis. However, 15.6% of all SNF stays utilized the Section 1135 waiver of the 3-day stay. Now, remember, those waivers were not just put in place for a COVID diagnosis. The waivers were put in place to prevent hospital utilization as much as possible because of the pandemic. So if a resident needed to be treated for a UTI, for example, because of mental status changes and needed lab work, etc., if they could have been treated in the SNF, without sending them out to the hospital for IV antibiotics and a new diagnosis, then the intent of CMS was that the SNF treated them in place and that they had the ability to initiate a Medicare Part A stay because of this. They didn't have to send them out just to be able to get that qualifying stay. So that did a huge amount to reduce inpatient stays. So to my mind, this indicates that the waiver was being used appropriately. So fewer than 84% of all stays began with a qualifying inpatient stay, which is, you know, it used to be a lot more than that because the 3-day stay was required. But not all of those stays had a COVID diagnosis. So that means the overall hospital utilization came down even for folks who were not being sent out for potential COVID. So my tip here is to make sure that there is appropriate documentation for why this person is being skilled in place. So there needs to be a documentation of medical necessity from the physician and the physician's certs. Now, the key here is that this waiver can be exercised if the pandemic is preventing that person from being sent out to the hospital in the first place due to concerns about the spread of the disease. So if it's at all feasible to initiate treatment in place and prevent that hospitalization from occurring, the physician can document this, document medical necessity, and start the ball rolling. The one thing that's really important is to establish what is day one of that stay. What's the start of the benefit period? So all your documentation, the certs, the billing, the MDS, everything aligns so that day one is consistent. Then you want to get those daily skilled notes going and make sure that you choose the right date for the ARD for that initial Medicare assessment MDS. All of those things would normally start the process rolling with the resident being admitted from a hospital stay, need to be initiated in the SNF. So you do want to make sure that all of those pieces are being done independently and aligned together. So you have the documentation to support that skilling. Now, therapy delivery, even though it doesn't impact PDPM, is a big area of scrutiny. CMS has been tracking changes ever since the switch from RUGs to PDPM, looking at changes in therapy delivery. And CMS has said flat out, they've seen a 30% decrease in average therapy minutes per day between pre-PDPM and post-PDPM, as well as an increase in concurrent and group therapy from 1% to around 30% away from individual minutes. So it's pretty obvious. I'm sure you've probably seen these graphs that CMS presents on showing how those individual therapy minutes cluster around 720 or 500 pre-PDPM, and now have kind of smoothed out afterwards. So it's obvious that the changes have been driven by the changes in the payment model. However, the good news here is CMS is admitting, hey, there have been no significant changes in health outcomes that could be tied back to that change in therapy delivery, such as falls or new pressure ulcers or hospital readmissions. However, CMS is continuing to monitor. They're going to keep monitoring for any potential adverse trends, and that's something you should certainly keep an eye on going forward. So any potential compliance issues that you want to make sure don't fall through the cracks, such as residents who are being isolated or who have an active COVID-19 diagnosis receiving group therapy. We would assume that would not happen. Or any inconsistencies between the ADL coding on the MDS and what the therapy documentation says. Remember, section GG is supposed to be an interdisciplinary process, not just one group contributing to this to find that usual function, and any inaccuracies in reporting functional outcomes. So this is something that CMS is watching, because the ADL functional score from the beginning of the from the PDPM stay to the end of the PDPM stay is becoming a quality measure, and any inaccuracies in capturing that score, or maybe cherry picking what goals you want to report on, because there is the best likelihood of success and making your QMs look better, is an area that you want to avoid. Just make sure that you're appropriately reporting all functional outcomes in the MDS data, and let the quality measure come out where it will. So the documentation to support daily skilled services, I mean, this has not changed. The requirements of participation have not changed. Medicare rules overall have not changed. So just making sure that the appropriate documentation of diagnoses, what treatments and therapy are being provided, and the notes that daily skilled services are needed for nursing or therapy or both. Making sure that your interdisciplinary team all have input into this process ensures that no skilled services are being missed in the documentation. I mentioned earlier, it's very important to get interdisciplinary consensus on that primary diagnosis and the primary reason for SNF care rather, and making sure that these services are reasonable and necessary, including the length of the stay in the SNF. And remember that the technical requirements have not changed, and they're probably not going to change anytime soon. So there has to be a qualifying event, whether it's the hospital stay or skilling in place under the 3-day waiver, and meeting those waiver requirements, as well as the physician certs and the recerts. Okay. So I have a few minutes left to talk about the quality reporting. So in the proposed rule, CMS also discusses any proposed updates to the SNF quality reporting program and the value-based purchasing program. So first up is the QRP. So the SNF QRP, which as a reminder is looking specifically at Medicare Part A beneficiaries. The two proposed new measures that CMS is proposing are SNF healthcare associated infections requiring hospitalization, or SNF HIAI, and COVID-19 vaccination coverage among healthcare personnel. And then there is one proposed change to an existing measure, so I'll talk about that really quickly. The transfer of health information to the patient for post-acute care. They're just changing the denominator to this to exclude patients who are being discharged home with home health or hospice services, because there's another measure for transfer of health information to the referring provider that covers that group. So anybody who's going home with services would be excluded from this measure. But remember, this transfer of health information measure is not being reported on yet, because the data is not going to be captured until at least 2 fiscal years after the public health emergency is over. So let's talk about the new proposed measures. First of all, the SNF HAI, healthcare associated infections requiring hospitalization. So this is a risk-adjusted rate of HAI that were acquired during the SNF stay that result in hospitalization. Now this is a claims-based measure, just like the CMS 30-day readmission rate. It's a claims-based measure. There are many exclusions to this that would exclude anything like a chronic infection or a pre-existing infection prior to the SNF stay, infections that are likely related to that inpatient hospital stay, or secondary infections, infections that are likely to be community acquired, or infections that are common in other countries or acquired through animal contact. So very specific exclusions here. But what CMS is trying to get at is the most likely these infections were related and acquired during the SNF stay. And then there is also risk adjustment included for age and gender and the principal diagnosis and the reason for the Medicare stay. Now this is all being captured from the SNF claim, or sorry, from the hospital claim. Now this is going to be publicly reported with the April 2022 refresh of Care Compare. So next April, you're going to start to see this measure being reported. The provider preview reports will be available in January of 22. And the initial reporting period is going to be fiscal year 2019, which is October 1st, 2018 to September 30th, 2019. So this time period is way past. So firstly, the first tip I would have is just assess your infection prevention and control policies and just follow up on any deficiencies that have been cited either from these infection control focus surveys that we've had during the pandemic or on an internal mock survey or audit or review. And just make sure that your medical director and your medical staff is on board for approaches to either both prevent infections through infection control and to treat in place when it's appropriate to, if the infection cannot be prevented, then the hospitalization cannot be prevented. So the initial reporting period is long past, but here's some things you can do to prepare going forward. The other measure is the COVID-19 vaccination among healthcare personnel measure. So this is the cumulative number of personnel eligible to work in the SNF during the reporting period who have received a full course of COVID-19 vaccine, whether it is the 2-shot Pfizer or Moderna or the 1-shot Johnson & Johnson. Either one of those would be considered a full course. So pay attention to healthcare, what HCP includes. So it's facility employees, regardless of whether they work directly with the patients. Licensed practitioners, adult students, trainees, and volunteers, other contact personnel, optional. So contract personnel. So if you have contracted therapy, for example, that's optional. Now the exclusion is for personnel who have a medical contraindication to the COVID-19 vaccine, and this is as specified by the FDA, the CDC, and the ACIP. So the HCP includes a lot of people, and there are very specific criteria for whether a person is excluded from this sample. Now, where does all this data come from? The National Health Safety Network, or the NHSN, this is the portal where facilities upload their COVID data every week. That includes the infection data as well as the vaccination data. Now, facilities have to report their weekly data at least once a month in order to be captured. So if you reported your vaccination rates twice during the month, the most recent week's data at the end of the month will be used for the calculation. Now, the reporting time frame is going to be a quarterly rate beginning with Q1 of 2021, meaning October 1st through December 31st of this year. And that will apply to the fiscal 2023 SNF Quality Reporting Program. Yeah, you need to have a manual to figure out what year we're in, but it's going to be, the reporting is going to begin with the last calendar quarter of this year. And then in subsequent years, the data will build up and CMS will follow that standard 4-quarter time period. Now, remember, healthcare personnel vaccination reporting had been optional up until the interim final rule that was published on May the 11th. So not only is HCP vaccination reporting mandatory now, it's also subject to civil money penalties for noncompliance effective June 13th. So starting this month, any noncompliance with weekly reporting of vaccination of your personnel will be subject to CMPs. So if you haven't been reporting, I suggest you begin now. Now, for the data refresh in SNF QRP, the data in the quality reporting program due to the pandemic is going to be held constant for calendar year 2019, will be held constant until next January 2022. And then the January 22 refresh will be 3 quarters of data, skipping Q1 of 2021. Sorry, skipping Q2 of 2021. So that will be 3 quarters. Sorry, skipping Q1 and 2 of 2020. Sorry, I got my years mixed up. Skipping the first 2 quarters of 2020, meaning skipping the beginning of the pandemic. So that will be 3 quarters worth of reporting, and then the April 2022 data refresh will resume the normal reporting period. So basically what CMS is trying to do is avoid those first 2 quarters of 2020 so that COVID-19 does not skew the data too much. Similarly, with this claims-based measure, the data will be held constant until January 2022, and then the 2022 refresh will refresh with 6 quarters of data, and then October 2022 will refresh again with another 6 quarters of data, and then the normal reporting of 8 quarters of claims-based data will resume in October of 2023. Now, I know we're getting short on time. There's just a few more things to go over. Now, for the SNF value-based payment program, COVID-19, of course, has messed with that as well. So for the SNF RM, the 30-day all-cause readmission measure, that is the VBP program, will be suppressed for the fiscal 2022 program year. So what this means is all SNFs who participate in the program are going to receive the same performance score. Everybody's going to be zeroed out. And all SNFs, regardless of their actual performance, because the data's being not being used in scoring, will receive 1.2% back from the total 2% program withhold. So, everybody's going to get the same amount back, except for the SNFs who are subject to the low volume adjustment. They'll get the full 2% back. So this is remember I talked earlier about a net decrease in the VBP program. This is where this is coming out. And basically it's because everybody's being zeroed out and receiving the same amount back. Now, CMS is going to actually report on the data with a notation that the measure is being suppressed for scoring due to the public health emergency. So that means that just because you're not going to be subject to potentially a penalty related to your SNF RM data, it is important because CMS is still going to be reporting on it. And then fiscal year 2021 Q4 will be used for the 2023 program baseline period. So remember, you're being compared to yourself at a prior year, as well as being compared to your peers. And then last but not least, CMS has said that they are looking for input on future quality reporting program measure concepts that include all kinds of information, such as overall frailty of patients, patient-reported outcomes, not just assessment-based outcome, decision-making, pain assessment and pain management processes, health equity, and CMS now has a statutory authority to add up to 9 new SNF value-based payment measures. So they're also looking for input from providers on what areas would be appropriate to add to the VBP. So there's going to be more measures to come. But the real key is compliance. So as always, the updates to the proposed rule don't change the overall requirements of participation in Medicare. They don't change the state operations manual. You do need to make sure that your organization is consistent in your overall compliance program. So make sure that when you're utilizing the skilled Medicare Part A benefit, whether through a qualifying hospital stay or under the waiver, skilling in place, that it's being done so appropriately, it's well documented, and that you are maintaining the resident safety and preventing infections or treating in place to prevent avoidable hospitalizations as much as possible. And that really ties into infection prevention and control, which includes COVID-19 as well as other infections. So the focus has really been kind of focused on COVID-19, but the broader point is still patient safety and managing avoidable hospitalizations. So overall good compliance will result in better outcomes for your residents and patients, as well as for your organization's quality measures.